This is Jan Skowronski, and welcome to Birmingham, Alabama. A beautiful city of southern charm, green mountains and colorful gardens, but also a city of rather perplexing history. On September 15, 1963, Ku Klux Klan detonated a bomb in a local church, killing 4 small African-American girls. Next to the site of the bombing, the Civil Rights Institute was erected, and that's definitely a place to visit when you come here. Times have changed since, and right now Birmingham is a powerful scientific and research place and the site of University of Alabama at Birmingham. And since I moved here 2 years ago, I have been a repeated recipient of Southern hospitality. On the medical front, every time I get up and go to work, it feels like this is the world capital of vascular disease. Thank you.
Hey everybody, Dr. Rob Miner here, coming to you from Montana for this year's Icarusconference. We're looking forward to seeing all the great presentations later today. Just some fun facts about where I live. There's a golf course behind me. You can hear some people playing golf. In the distance, there are ranches and a buffalo herd. Where I live, there are more elk and antelope per square kilometer than there are people. We also have the highest concentration of grizzly bears in the lower 48 states. So when we go hiking with my family and friends, I have to take bear spray with me. So we're really excited about today. We're going to look forward to seeing you later during the case conferences and the discussions. So once again, welcome to today's meeting, and we'll look forward to seeing you soon.
We talked a lot about mentoring. So if you don't mind, I have to welcome Rob Miner.
Sure.
Because in the last session, we talked how important mentorship is. It's essential. And actually, Rob has been my mentor for endovascular procedures. When I came fresh out of fellowship, I had absolutely no clue how to do endovascular procedures. And now I spend 70% of my procedural time doing endovascular intervention. So Rob, welcome. And thank you for everything you have done for me and, of course, for the patients. And you're talking from Montana. And please.
Okay, Jan. Well, thanks very much. Of course, it's always great as a mentor to have your students exceed you and all of your expectations as you have done, and I congratulate you for that. So I'm going to be talking today about a case that also involves at least one complication. Jan was hoping we could show some complications as well. And this involves the treatment of a flush osteocclusion of the left SFA using some novel approaches and dealing with some issues that come up during the case. I like this picture I'll bring up for you here. It's a picture from close to my home. This is a grizzly bear walking along a river, and you see the mirror image, which reminds me of the problems we face in the lower extremities. Often there's a mirror image problem in the other leg. We have to keep in mind both legs when we're treating one. The other is don't poke the bear. How many times have you heard that phrase when in fact when we're doing endovascular procedures, we're poking the bear in every case? And then lastly, be prepared for things that can occur in the cath lab that you want to be ready to address and take care of. These are my faculty disclosures for this case. Interesting patient, a 44-year-old male. He smokes, he is statin intolerant, has multiple risk factors. He had a spinal cord injury as a firefighter in Montana.
Rob, I think you need to share your screen.
Nope.
Because we see you, but we don't, you need to click on share your screen, and then here we go.
There we go. Sorry about that. So the case is a 44-year-old gentleman with multiple risk factors. He had a spinal cord injury as a firefighter in Montana. He's wheelchair bound the last 6 years, but he gets around pretty well. He drives a pickup truck using hand controls. He's married. He's had a wound for more than 3 months in his left foot. His ABI on the left is 0.4 and the right is also low. One of the problems is he has some hip flexion contractures. It's difficult to extend his thighs completely when he's laying supine. But he has completely refused amputation as a treatment, and he's very concerned about getting gangrene and sick from that. He also is concerned about any additional radiation or dye. He doesn't want a CTA study. And he was referred to me because he knew that we were doing same-day angiography and endovascular therapy pretty routinely. Here's some pictures that are very interesting. Even though we use ultrasound access, this was my case, with his hip contracture flexure inadvertently stuck high. And you can see me going to an area of the external iliac artery close to diffuse disease. Angiography of the left iliac artery showed this ostial SFA, chronic total occlusion, and runoffs in the legs showed that it extended about 20 centimeters. Fortunately, in both legs, this gentleman had 3-vessel tibial runoff and gave us the opportunity for treating this. So what was the interventional plan in this case with ostial left SFA CTO? We were using a 7 French crossover sheath from the right common femoral to left common femoral for an antegrade approach, and ultrasound guided retrograde access from the posterior tibial artery and the left leg. An angled glide wire was advanced retrograde from pedal access and really crossed the CTO very easily using microcatheter backup. We then brought a snare around from the groin to externalize the glide wire through the sheath and exchange over a microcatheter to deliver a filter antegrade for embolic protection, because our plan was to proceed with atherectomy and DCB therapy. So we had the contralateral access in place. This is where we're going to position our snare. And retrograde access was obtained easily through the posterior tibial artery, with catheter advancement across the total occlusion really in just a matter of a few seconds. Here's dye being given through the transpedal access catheter to allow us to then grab the snare and externalize it. It's in a relatively simple matter to exchange for a filter and to advance our atherectomy catheter using directional atherectomy through the origin and throughout the entire length of the chronic total occlusion. After debulking, we then used a paclitaxel-coated, drug-coated balloon, 250 millimeters in length, for a single inflation across the entire length of the lesion, including the ostium. So we were very happy. The case was going very smoothly. We thought we were going to finish soon, and we did some completion angiography. I'll point out this is in a 35-degree LAO view that opens up the SFA and the profunda. You're going to see we had a pretty significant perforation close to the ostium of the SFA, where we had done some aggressive atherectomy. And in our lab, this is really a good indication for proceeding immediately with stent graft implantation. And as you'll see here, using the antegrade approach, it's easy with contrast injection to position a stent graft at the origin of the SFA. This is a Viabon. And with release of the graft and additional dye, we can confirm excellent placement. And then after post-dilatation, our final result. So this was relatively simple to deal with. Here's our completion angiogram showing the area of stent graft implantation, atherectomy, and DCB therapy. And excellent flow into the runoff vessel. You can see the anterior tibial artery filling the pedal arch well. And I included this image because I wanted to show that the bifurant sheath in the posterior tibial artery does occlude flow to a certain degree, but it is removed immediately upon completion of the procedure, and we use a transradial band on the ankle to achieve hemostasis. So we're all kind of excited about completing this case when I reminded everybody we still had a problem to deal with, the high stick in the right external iliac artery. And what are the solutions to this problem? Well, we could pull the sheath with manual compression, but this is an area that really cannot be compressed. What about vascular closure devices? Angioseal vascular closure plugs tend to bleed late. Perclose, we'd be kind of in an area of diffuse vascular disease. Other ideas? Well, on the left leg, we knew we could easily visualize the top of the Viabon stent graft. That's the origin of the SFA. And using some other cheaper ways, identifying the femoral head, and with ultrasound, we're able to get access and bring a sheath around with a guide wire across this area where we stuck the right external iliac artery, and advance another Viabon stent to seal the hole that was created by the 7 French sheath. You see we centered that perfectly across the access site. And in this video, you'll see us removing the sheath as the Viabon is deployed. The wire was easily pulled out as well. and then final deployment was made with a 7mm balloon in the Viabon at the site. Serial hemoglobin measurement showed no fall in hemoglobin, and he was discharged the following day on dual antiplatelet therapy. What was their outcome? He had complete healing of his left leg and foot wounds. We did a stage intervention in the right SFA with atherectomy and DCB. At 1 year, which was just a couple of months ago, his ABIs are 0.9 in both legs, and he has agreed to the new Repatha injection therapy for dyslipidemia. He did reduce his smoking of his Marlboros, but only down to 3 cigarettes instead of 20 a day. And you might know the Marlboro man actually died from lung cancer. And I'm surprised they showed this guy with his legs looking pretty healthy. Of course, they may not stay that way. So what are lessons learned from this case? Certainly I learned some lessons. The value of retrograde pedal access for SFA ostial CTO. The need to have stent grafts available in the lab for bailout for arterial perforations. Be prepared. The use of the stent graft for sealing a point of high access in the external iliac artery. And my personal feeling that debulking the SFA and DCB therapy with filter protection is inexpensive, but maybe most effective treatment and durable treatment for SFA disease. So Montana is a great place to live. It's called by many the last best place. And we have the highest concentration of grizzly bears in the lower 48 states outside my back door. But whenever I go hiking, just like in the cath lab, I'm going to be prepared and bring bear spray with me. So thanks very much, guys. And hopefully that case was instructive and we all learned from it.
This is Jan. Rob, thank you so much for presenting the case. We probably would like to ask you a question or two about the case, but I'm a really terrible host. And we jumped to your presentation without introducing other members of the group. So I would like to say hello to Jafir Golzar from Chicago, and Alan Lumsden from Texas, from Houston, Lorenzo Patrone, and we also have Dr. Grzegorz Stasiuk. So hello, everyone. We'll proceed shortly. But does anyone have any questions to Rob Miner regarding his case? I think it's highly educational.
Sure. May I ask him a question, Rob? So you
Hey, Alan.
Hey, how are you?
Great.
You started off by saying same-day angiography. Well, that kind of got my attention. Elaborate a little bit about what that means.
Yeah, well, we don't use a lot of CTA here because we have people traveling so far to see us, sometimes 2 or 3 hours. We've been so used to same-day cath intervention with PCI therapy that we've adopted that for some of the patients who are coming in for peripheral vascular therapy after they've had non-invasive tests. So we do try to get that done in local hospitals, but are offering more and more people the option for a single procedure for both angiography and intervention.
Yeah, it's interesting. When I first visited Ted Dietrich at Arizona Heart, that's the way they had it set up. They did clinic in the morning and they did the diagnostic angiogram and the intervention that afternoon. And some of those patients went home. So we've never really done that, but it's an intriguing idea.
Well, I will tell you, it's a big patient satisfier. We know it's a cost saver, maybe up to $5,000 per case now. And whenever possible, we're doing same-day discharge.
Yeah. Nice case.
That's for. So Rob, this is Jan. In reality, statistically, if you do 100 endovascular cases on the leg, whatever it is, how often do you use pedal access? How many percent in your best judgment?
Yeah, it's increasing all the time. I think it's probably less than 20% now, just because we can get so many of these cases easily from above, and we have to use bigger sheaths for most of the atherectomy cases. But I think as we miniaturize the equipment more and more, where we can go 5 French on most cases, I think it's going to be really nice and easy for patients after a transradial band on their ankle to walk out of the hospital a few hours later. I still am a little concerned about doing atherectomy and debulking because of the lack of distal embolic filter protection when going transpedal. So I do prefer the contralateral or antegrade approach.
Absolutely. Okay, Rob. Well, thank you so much. And I think we'll move to Jafir Golzar, who is a good friend from Chicago. And he also works a lot with the industry. And he's a real leader in the field. Jafir, the floor is yours.
Thank you, my friend. Give me just a second. Let me try to share my screen here. Can you guys see it? See the screen?
See it perfectly.
Awesome. Thank you so much, Jan. Jafir Golzar, coming to you guys from Chicago. It's really an honor to be part of this program and follow such great leaders in the endovascular world. And thank you for the opportunity. So my thought today was to have a presentation on popliteal artery intervention. So I'm going to start with a case that I did last week, a 75-year-old male. Obviously, we're still in Chicago. We're still not doing elective cases. So everything we're doing are critical limb ischemia, both inpatient and outpatient. So 75-year-old male, he was admitted to the hospital with critical limb ischemia, and we were consulted for that. So we brought him the next day. He had had symptoms of rest pain in his left foot, present for several months, and interestingly, it was so severe that he became so debilitated that he stopped walking. And about a week before his presentation, he also subsequently had a DVT. So he had a CLI, no ambulation, developed a DVT, and that was, we also lysed that, we did an RE for that, and that's a different discussion, and we found that he had Maytherner, but today I'm going to present this case. So popliteal artery case, CTO of the popliteal artery was seen on angiography. As you can see, right at the level of the adductor canal, there's a large collateral that comes off, and the CTO traverses the entire length of the popliteal artery and reconstitutes at the popliteal never reconstitutes. Their only vessel below the knee is the anterior tibial artery, which is also has a stump occlusion in the ostium. And so the tibioperoneal trunk is occluded, peroneal and posterior tibial arteries are occluded. So really the anterior tibial artery was the only viable vessel below the knee. So we'll get back to that case, but we want to go over a little bit about the anatomy of the popliteal artery. So as you guys know, the popliteal artery is essentially just a continuation of the superficial femoral artery, and it changes the name from SFA to popliteal artery at the level of the adductor canal. And the popliteal artery extends from the level of the adductor canal to the anterior tibial artery. And that's where the name and the popliteal artery exists. So there's three segments of the popliteal artery. There's the P1 segment, which starts from the adductor canal to the top of the patella. The P2 segment, which goes from the patella to the knee joint. And the P3 segment that goes from the knee joint to the origin of the anterior tibial artery. And this is important because there are different treatment modalities that you have to think about when you're thinking about different aspects of the popliteal artery. And we'll get into that in a little bit. So what are the challenges in the treatment of the popliteal artery? I selected to talk about this because there's a lot that goes on, and there's a lot to think about when you're treating the popliteal artery. So first and foremost, there's these flexion points in the popliteal artery. It's because there's two fixed points in that segment. There's one fixed point at that level of the adductor canal, and then the other fixed point is the level just past the origin of the anterior tibial artery. And between these two fixed points, there's a significant amount of movement in the popliteal artery. So when we think about the P1 segment, what happens to that artery is it dives behind the adductor canal, and there's a great area of movement in this segment. And you have to think about the fact that this is usually where a femoropopliteal bypass would have its distal origin. And so we have to be very thoughtful not to close out any options for that. In the P2 segment, you see the origin of multiple geniculate arteries. And again, being careful about not compromising those geniculate arteries are important consideration, as well as the bend point in that segment. Now, the P3 segment is much less mobile, but there's a significant size mismatch, and that's where the infrapopliteal arteries also take off, and so you have to be thoughtful about that. And we'll get into sort of treatment algorithms as we get into the talk a little bit more. Now, everybody really thinks about this when we think about the popliteal artery as the flexion points. And why is that important? Exactly what we talked about before is the two fixed points of the adductor canal and just distal to the anterior tibial artery. A lot of mobility in between those two segments. This was an interesting study where they looked at a resting gradient both at rest as with the leg extended as well as with knee flexion. And even without any disease, you see a significant gradient that forms in the popliteal artery. And especially have to be thoughtful about using a covered stent in these situations, and really a stent at all. And we'll get into what are the ideal stents to be used in these segments. So what are our treatment options? Angioplasty, and this would include shockwave as well, focal force angioplasty, plaque modification angioplasty, atherectomy, drug-coated balloons, stents, and surgery. So show me the data. Well, unfortunately, there's not a lot of data. There's really limited randomized control trials. There's some retrospective studies. There is one study that looked at that compared stent implantation to angioplasty. And it was 246 patients for a short lesion length of approximately 42 millimeters. They were randomized prospective study. And what they found was that the primary patency was significantly higher with the stent group than with the angioplasty group. However, they did find also that if the patient needed a provisional stent, so if they had a flow-limiting dissection, if they were initially randomized to angioplasty, they had a flow-limiting dissection, and then you had to put in a stent, those patients did the same as a stent and angioplasty arms did the same. There's also a study that looked at bypass, but I didn't include that because that was bypass versus endovascular for popliteal aneurysm. And then this study is what brought Supera on the market and kind of excelled it to become sort of the paradigm for treating popliteal disease. Is a interwoven nitinol stent, which is different than the traditional stent, which is the laser cut nitinol stents that we usually have. So this was a retrospective study with with popliteal artery intervention. And what it showed was that at 6 months, again, it's only 6 months, but the primary patency was 94%. And at 12 months, that patency did drop down to 87%, but still pretty good for the popliteal artery intervention. And when they did x-rays on these patients, there was no stent fractures. Now, there are multiple stents that have included the popliteal artery in their intervention. And the most recent one is the Alluvia stent, and I know Jan kind of mentioned this a little bit ago. We were honored to be part of that in the trial. We're also published in a couple of published the patient on the imperial long, and these patients popliteal artery were included in these patients. So it was a femoral popliteal, but you could not exceed past the P2 segment, so past the knee joint. But as you guys know, this was a head-to-head comparison with Alluvia versus Zilver PTX, and there was a clinically driven reduction in TLR as well as primary patency at 1 year. This primary patency did not reflect back out to 2 years, but the TLR was significantly better from Alluvia over Zilver PTX at 2 years as well. And this was across all boards along with our long lesion subset as well as diabetics and CTOs. So those are stents. So what about angioplasty? Angioplasty is easy, it's inexpensive. Really, there's no permanent implant, and I truly believe in trying to not leave anything behind if I can. But if you need to use a stent, you need to also know your options. The disadvantage, dissection. How do we deal with that? I believe in long balloon inflations, at least 2 minutes. Low and slow is what I say, 2-minute inflations for 2 to 3 atmospheres to really minimize barotrauma. But then you can also get recoil, really limited role in calcium unless you debulk first, and very high restenosis rates with angioplasty alone. Then we get to atherectomy, and this is sort of my choice. There's so many different options, and there's no head-to-head comparison, as you can imagine. You can shave, cut, burn, pulverize the plaque, the thrombus. Great for calcium debulking, for vessel pret, prior to angioplasty and drug-coated balloons. The disadvantage, added cost. There's a learning curve associated with it. I'm a believer in using distal protection. Some people do, some people don't, but then you do have to advance your distal protection device as well. So the advantages and disadvantages of atherectomy. As we kind of alluded to before, there's stents, and usually the advantages here, it's great for bailout for flow-limiting dissections. Covered stents can be used for popliteal artery aneurysms. And really the radial force when you do, even if you debulk and you still have residual calcium, having that radial force to prop that up and improve your luminal gain is one of the advantages with stents as well. My choice for the popliteal artery is really the superior stent, especially if it passes the knee joint from P2 to P3 segments. I also use Illuvia if it's a P1, P2 segment, and the newest kid on the block is the TAC stent, which is the micro self-expanding stents, very low radial force, but it can also be used in these locations. The disadvantages, unfortunately, it does close the door for future bypass in the popliteal artery. It can compromise geniculate arteries, although it's maybe a little bit less of a concern with non-covered stents. And also the continued high stress with traditional nitinol stents. Some believe that has continued barotrauma and can increase restenosis rates. And that's, I think, where the drug elution part comes in and helps hopefully prevent restenosis. Surgical therapy really are reserved for those patients that have recurrent restenosis, failed intervention, or popliteal entrapment. So let's get back to the case from the other day. Again, 75-year-old male with critical limb ischemia, popliteal artery is occluded into the anterior tibial artery with the stump occlusion in the anterior tibial artery. And as you can see, there's a large collateral that comes off there as well. So we did try, we had a crossover access, 7 French sheath was used to engage the left common femoral artery. Then we had a Navicross catheter and a glide wire. I initially used that to penetrate the proximal cap, and then switched out to a V18 wire to penetrate into the infrapopliteal vessels. The problem was I kept getting my wire into the peroneal artery, and I knew because of that stump occlusion, I really wasn't going to be able to engage the anterior tibial artery, which is sort of the low-hanging fruit for me to go after. So we had the foot prepped already. We usually do that with most of our cases, especially with CLI. So we very easily prepped the foot, accessed it with micropuncture needle and wire, placed a O&A Trailblazer and a treasure wire and crossed it. So from up top, we had a Navicross catheter and we had a treasure wire from below. We externalized it through the Navicross, the retrograde wire through the Navicross catheter. And then this allowed us to then just advance the Navicross down into the anterior tibial artery through that retrograde wire. Now we know we're true lumen through the whole segment and get into the anterior tibial artery in that way. Oh, sorry, guys. So after that, we performed directional atherectomy and angioplasty, and despite using, what I felt was a 1-to-1 size balloon in the popliteal artery, 4 millimeter in the P3 segment into the anterior tibial artery, low pressure balloon, as well as kind of a 1-to-1 segment angioplasty of the popliteal artery in the P1 and P2 segment. After atherectomy and angioplasty, we did have a significant dissection, which I really didn't feel comfortable leaving. So we did place an Illuvia stent in the P1 and P2 segment, and then you can see the results there. Now you can see around 45 to 55, there is some area of what looks to be disease, but it's actually just spasm from the filter. And so we treated that with nitroglycerin. Obviously, with the filter moving up and down, we expect that to happen. And so that went away pretty quickly. So what is my personal treatment algorithm? My personal algorithm is I use atherectomy with DCB if clinically indicated. Obviously, critical limb ischemia, recurrent stenosis, high risk of recurrent disease. I like that because there's no permanent implant. I like to debulk, perform vessel prep prior to drug delivery. Stent implantation only if there's heavy calcium despite atherectomy, or heavy dissection after treatment of a CTO, as alluded to in this case that we saw. In the P3 segment, it's pretty much the same as above. The only thing that I add to that is P3 segment, I do consider coronary DES because there's very little mobility and motion in that segment. And so coronary DES is applicable. There's not a lot of musculature, soft tissue that will crush that stent. Now with the TAC stent, we literally got it approved. We were part of the clinical trial, but we literally got it approved this week. So we'll have that on board. I'm sure I'll be using that a lot in these segments. I think that would be a sweet spot for that. So in conclusion, I believe that it's important to understand the anatomy of the popliteal artery and understand the flexion points of the popliteal artery, and really understanding that will help create your own treatment algorithm and how to treat these patients. There are multiple treatment options based on the pathology and segment of disease. My personal treatment option is atherectomy, followed by angioplasty and a drug-coated balloon implantation. If there's no dissection, and if there is a dissection or residual stenosis, a stent implantation. Thank you very much for the opportunity.
Jafir, thank you so much. Great case, fantastic. So I have kind of a global question to you. As you know, sometimes I go to Europe and I participate in some cases, and European wire and balloon skills are just unbelievable. I remember I'm with this guy in Krakow, Poland, and severe iliac disease, severe SFA disease, popliteal disease, and tibioperoneal trunk. The guy takes one wire, one very compliant balloon, and just treats it all. So their wire skills are just, and angioplasty skills, unbelievable. At the same time, we know that you're a world master of atherectomy. And atherectomy of any kind has never really taken up in Europe that much. So here is the challenge. A lot of our patients, if they go to Europe, they bring their Brilinta, they bring their Effient, because it's about 20% price for what they have to say, what they have to pay in the US. Shouldn't we kind of do the same with devices and significantly discount prices for all kinds of atherectomy devices? So the rest of the world should be more, they will adapt it perhaps easier. I think there is some cost barrier in adoption of some technologies in endovascular medicine. Thank you.
Yeah, no, that's a very good question. And, we do treat patients differently based on our skill subset, our comfort level with devices and treatment algorithms, and the fact that we don't really have the data to compare stent versus atherectomy. Who knows who's to say who's right, who's wrong? That's my personal belief, is I believe in, atherectomy. Now, that being said, as you know, I'm chief medical officer for a medical device company as well that sells atherectomy devices, and we do sell it in Europe, and it is sold at a discounted price. But even with that discounted price, the problem is there's no reimbursement except for in Germany. And so whenever we launch a device, we always go to Germany for our initial launch for atherectomy, because really that's the only place that they have reimbursement. So unfortunately, the hospital loses money if they use these devices, even though it's a lower price for Europe, India, South America, Asia than it is in the United States. As you know, we pay the highest in medical costs for anybody. So I think some of that regulatory thing, the regulatory concepts need to change, And it's these physicians that need to spearhead that to really try to get the politicians on board to try to help change that paradigm.
Thank you, Jaffer. Any other thoughts or comments or questions regarding Jaffer's presentation?
Yeah, this is Alan. Hey, Jaffer, there's a nice case. Give us two questions, really. How long does it take to do the case? I mean, give us some idea of just what we're getting into when you're crossing up popliteal and then coming retrograde. How long did it take? And then the second question is, tell us a little bit more about the Navicross catheter you're utilizing.
Yeah, great question. So, when I first started my career and started doing these cases, I would spend, 4 hours, 5 hours doing cases. And, as you probably know this, your back is hurting and then you're stressed out and the patients are not doing well. And then I kind of, as I became more and more a little bit more, capable in doing these cases and a little more methodical and algorithmic, I kind of set a rule of no more than 2 hours for any of my cases. So, 2 hours is sort of my limit. Obviously, if you have issues and sometimes it just happens that you're going to go longer, but usually these cases, that was about an hour 15 minutes of full anesthesia time with retrograde access, antegrade access. And I've that's kind of what I teach my fellows: do it the same way every time. And I'm not saying my way is the right way, but in my brain, that's how I know I'm going to cross it like this, I'm going to do this, I'm going to DCB. So I'm not perseverating and overthinking and staring at the screen and saying, what should I do now? So I created my algorithm so my cases go pretty fast. So so that's one thing. And then your second question, I'm sorry, what was that?
Navicross catheter.
Oh, Navicross catheter. Yeah. So, I used to, I really like the Navicross. I started using it about an hour ago, about a year ago. It's made by, not an hour ago. I have a little bit more experience than that. It's made by Terumo. It's got a little tapered tip, a little bit of an angle to it, hydrophilic, and it's got a really nice stiff shaft to it. So it provides great support. So I use it with a glide wire. And I've tried some other ones. I used to use Trailblazer, Quick Cross. I've kind of used them all. I like the bend and the hydrophilic nature and the shaft of it that really allows me to, sometimes I just push the Navi by itself without a wire as well and just kind of stays true lumen. So it's a nice catheter.
All right, thank you.
Thanks, Alan.
This is Jan Skowronski. Thank you so much, Jaffer. It's interesting, but I'm going to skip my presentation with an exception of 1 or 2 slides, but I also will have actually a Navicross on it. But right now we will move to the next speaker, Lorenzo. Lorenzo, you're on. Good to have you. Please go ahead.
Hello, thank you very much. It's a pleasure to be here, to be invited. And the title of my presentation is Fit Fighter: Complex Infrainguinal Recanalization from Groin to Toes. So a case that took a little bit more than an hour, but sometimes, as Dr. Golza said, he needs to take what he takes. So it's let me go away. So I'm a consultant for these kind of companies. So this is my conflict of interest, and this is my background of this presentation. And I think you all are very comfortable with this from the 90s, Street Fighter, and you can see how this. I don't know what is okay. Like a Street Fighter is coming on, and there were 2 guys named Ryo and Ken, who were fighting all the time. And this is my personal version. It's Fit Fighter, where I am one of the guys, and the other guy is the patient who gently gave her the permission to use her image. And so this patient was an 81-year-old who was diabetic, ex-smoker, 90 kilograms. And she presented with a wet gangrene at the first toe, right foot. And she had a surgical history of fem-fem crossover, which was occluded, and a second toe amputation, and as you can see from the picture. And she also had an endovascular story, right coronal stent, which was still patent, but a right SFA stent, which was instead occluded. So round 1 fight, I put her on the table because of the high amount of scar. I prefer to get an up and over approach, and also because you can see how here the stent is occluded here at the level of the SFA. So I decided to go up and over. I got a SIM catheter to cross safely without going through the structural stent. I put my guide wire, stiff guide wire, up and over, but I was struggling to put the sheath over, and probably because of this kind of a small bend of the stent. But I didn't realize that I lost by pulling and pushing a piece of a catheter there. So when I even tried to put a balloon to do like you do in a superior mesenteric artery to push the sheath over the hill, then I pushed the catheter even farther, and finally I really realized that the catheter was lost over the wire. So I think it's a nice problem that can happen sometimes. It happened to me like 3 times in my life, to lose stuff over the wire. So what you do, you take a snare, you put it over the wire, and while you're pushing down, then you close it. So the snare is closed and it can be advanced with a very low profile. And this is what I did. You can see the snare with one of the flowers around the wire, and then I snare out the cutter and job done. So this is just to start, and I didn't even start the case properly. So I forgot about putting the sheet up and over. I just went with the cutter. I was with a Navicross too. You can see how the stent is occluded there, and the SFA was reconstituted quite high at the level of the let's say mid-distal SFA, and these were the tibial vessels, so nothing really going to the foot. The peroneal was the only vessel giving then collaterals for dorsalis pedis, but the peroneal itself was occluded. So I tried to pass the stent from an anterior access. My attack didn't work at all, so I had to switch to a retrograde access. So I'm always trying to be as minimal as possible. So I really rarely use a sheath. I always use the V18 wire and a CXI catheter, which I find very useful in these cases. So I recanalized the stent quite quickly, I have to say. And because I couldn't re-enter there, I used my secret tool, the Outback, inserted a sheethless, so 6 French diameter from the retrograde access. And I re-entered quite easily. First shot, you can see how the needle puncture and even got in contact with the Navicross. Then as there the wire outside, I did all my angioplasty with a 6mm balloon, and I got this result. This result was not extremely good, and I thought that something more should have done. So I thought about the presso technique, which is to put the supera from the retrograde axis, and this is what I did. So I, of course, deployed the stent a little bit into the patch to be sure to cover the ostium of the SFA. And you can see how when I deploy the supera, the radial force or radial resistance of the supera pushes the struts of the other stent away. So just to show how the stent into the stent with supera works. And I finished, of course, deploying the stent quite close to my retrograde axis. I try to be always quite accurate in the length of the stent which I use, not to go out from the groin. And then I got into the stent from my antegrade axis. And of course, I put a wire over the retrograde axis I want to just to say that the 6 French Outback and 6 French supera is the same size of a 4 French sheath. So not a big thing. So I inflated the 6mm balloon while removing the axis, and I got this nice result. So the stent was patent again, and the SFA was running fast into the popliteal. But of course, you can't leave a patient, especially with this kind of toe gangrene in these conditions. And I decided to try to go for some of the BTK vessels, and the wire, of course, went straight away, as Dr. Golzar showed before, in the TP trunk, in the peroneal. I was quite happy. I was intraluminal. I dilated with a 3mm balloon, which I thought it was the minimal caliber for such a patient, and actually the result was quite good. So you can see the 2 runs at the level of the foot. I always take an anteroposterior view of the foot, especially in this kind of toe necrosis and infection. So I decided that the small collateral connecting the peroneal artery to the anterior tibial artery was enough for this patient, and after a few weeks, after 2 weeks, the foot was far better. So you can see how the inflammation, the infection went down. Of course, the tip is necrotic, and we waited. And I thought this was the KO. Probably I said, the toe will amputate, will self-amputate, or probably will do it later. But essentially, the patient came back after a few weeks again with signs of infections, and you can see how the toe is again very swollen and very edematous. So we did a scan, and what was found, like the SFA was patent, but the tibials were not intact. So this was like the patient calling me again, and I have to say that we had a very relaxed MDT discussion where the surgeons, of course, I'm a vascular interventional radiologist, but mainly the surgeons wanted to do a bypass, but because the patient was seen in my clinic and I thought I could have given a good angioplasty in the anterior tibial artery, I took the patient back to theater for the round 2. So the round 2 demonstrated finally finally I got an antegrade access because I wanted to treat the pedal vessels, and I demonstrated that the SFA and the popliteal were patent, were good. But if you go at the level of the tibial vessels, the peroneal artery is again not perfect, with anterior tibial artery which is still occluded. So I thought I should have given a better chance to this patient, which because of the disease was quite aggressive. I decided to puncture the anterior tibial artery retrograde just to not to damage the landing zone for the bypass. So I punctured onto ultrasound guidance a little bit higher than the collateral that we have seen into the previous runs, and I reached the top, but I couldn't re-enter. So it was a struggle. The patient was under local anesthesia, so I decided again to try to do something more. Again, my retrograde access, I put another, again, the outback. I remember is the same size of a, if you put it like, of course, sheetless over an 018 wire, is the same size of a 4 French sheath, and I push it up very easily. It's not difficult when you push it over the 018 wire, which is not from IFU, but I find it very useful and very handy. And I just reached the top, and very easily I re-entered straight away, first shot, and the wire passed intraluminally. So I, of course, reversed my access. So with the Navicross catheter, I have always 2 wires. So the 018, which is through and through, and then I pass an 014 wire, which passed this. I removed my retrograde access, inflating a balloon with good hemostasis achieved, and I got this nice result also stenting the top of the anterior tibial artery because it was very difficult to cross. And this was the result, and I was pretty happy. But because I felt, I could have done something more for such a patient, I said, okay, why not to pass again in the peroneal artery? Because I thought it was easy, but then I couldn't do. So I decided to go retrograde. This is my fluoroscopic guided access to the peroneal, which is pretty straightforward because you just go straight to the vessel. It's not very difficult. I put the wire up, and I thought that the wire would have flown through, but this didn't happen. So the dissection flap, which I created the last time, probably was a bit more difficult to cross. And I decided, because I had the outback on the table, to put the outback retrograde also from the peroneal access. I tried to re-enter, but I was into the vein. I struggled a bit, and so because I wanted to be quick, I used the other trick, which sometimes I use, the re-entry by puncture of the outback into the balloon. Essentially, you inflate the balloon from the top or from the bottom, and with the same catheter you were using before, you just puncture into the balloon, so you burst the balloon, and by putting the wire inside the balloon, then you retrieve the balloon into the, of course, safe landing zone where the catheter is intraluminal. And this is a very nice and quick and effective way to snare these kind of wires. We're publishing now our case series with more than 20 cases of this in any kind of district. And this is the final angiogram. So you can see the SFA and the POP are patent, and same for the anterior tibial and the peroneal artery, which are running together to the foot. That's a very nice sign of good flow. And I was very happy, especially for what regards the flow at the level of the first toe, which was very strong and direct. And you can see here the peroneal biphasic flow after also the angioplasty and the toe amputation. And you can see here the anterior tibial artery. I hope you can hear the sound of very good and strong flow. I always do the Doppler signal on my patients after they come back from the operating theater. So you can see also there's the VAC pump on the first toe, which was amputated. And this was the patient. We thought it was all right, so we also put some beads at the level of the cavity there. We closed it, and the result was very good. And I could say this is the end of my presentation. I thank you for your attention. But actually, what I want you to appreciate is, like, our honeymoon didn't last very long, and she came back to trouble me. And so actually it was completely healed, but she started having a second toe ulcer. And it's just to stress how it's important for this patient to follow the orthotics, all the prescriptions after the recanalization. And sadly, the whole thing went down. So the SFA stent went down, and also the tibials went down. So you can see that, interestingly, only the stent at the level of the anterior tibial artery is patent there, but all the tibials are again down. So you can see how the level of the foot, more or less, we have the same flow of the when she came for the first time. So I was retrospectively looking at what I could have done differently, and probably I thought that I was a bit too much positive in not stenting the peroneal, TP trunk and peroneal artery, because it already went down once. Probably this could have been one of the causes of the disease. And also, if you look at the angiogram of the foot in very much detail, you can see here at the level of the reentry, probably I could have used a shorter balloon, a 3x40mm balloon, to try to achieve a better result, to avoid a dissection. So this is like something, sometimes it's good to look at the cases retrospectively, because at the moment you are so happy about the result and then you don't notice. So essentially the patient had the bypass finally, and the bypass was running well, and 71 centimeters a second. But these were also the complications that she had after the bypass. And essentially, you see, like October last year, after almost 1 year, she was with still the wound at the level of the distal landing zone of the bypass open, and the bypass then went down. And this is typical for these patients who are not very, keen to be treated anyway. And with the pop graft occluded, now we are trying to treat her with a conservative treatment, and the ulcer has resolved the second toe, but still, those osteomyelitis, and God knows how we'll continue. And my final message is that we are anyway talking about persons, so we have to try to do our best endovascularly, openly, any kind of way for these CLI patients that we know sometimes they're very challenging. And I want to quote this man in this movie, famous Patch Adams, who says, "You treat a disease and you win, you lose. You treat a person, I guarantee you, you will win, no matter what the outcome." And with this, I thank you for your attention.
This is Jan Skowronski. Lorenzo, thank you so much. Excellent treatment, outstanding treatment of this patient. But I have so multimodality, multi-level, just unbelievable. And I'm delighted patient did well. I do have one or two questions regarding this, and I hope my colleagues will join me. It's regarding re-entry device, which you use actually, if I recorded it correctly, twice in this case. I just don't see it used a lot. This is, in my opinion, indispensable device. Those long arteries, something always goes not the way planned, and you get extra luminal. And I don't understand the lack of adoption, at least here in the US. Like what I learned that in Birmingham, Alabama, there are only like one or perhaps two other physicians using it, and no one is really kind of using it routinely. So thank you. Back to you.
Yeah, I think, when I was younger, I felt like using a re-entry device like a failure. So I'm not good enough to cross. So I felt like, okay, now finally, after 3 hours of trying, retrograde, antegrade, cart, reverse cart, double balloon, then it doesn't work. And when the flap is as big as a banana, then you try to use a re-entry device. So I think this is and then I changed slightly my practice, and especially when I go retrograde, because I do many patients where they're already a previous surgical treatment, then it's very useful. I mean, to use it at a very early stage, these patients can have a chronic kidney disease, and they can have also, difficult arteries because of a previous surgery, scar groins, and I think it's an excellent tool. You as Professor Goldzar was saying before, you just need to have it clear in mind what's your algorithm. So it's the same with the retrograde access. For me, like if I don't go intraluminal, if I struggle in re-entering with the loop, then I straight away go retrograde. This, I think I go, we're talking about before 20% of the cases with Dr. Minor in his practice. I think I go between 40 to 50%. Always sheetless, but I always go retrograde when I can't cross, because I think it's very useful, and to pass the wire through and through, and to try to save landing zone. Because if we try to dissect from the antegrade axis, then it ends up with the possible devastating effect on the distal landing zone. So I think both retrograde access and re-entry device should be used quite early if needed, and we all have to be very clear in mind the potentiality of that.
Thank you, Lorenzo. Any other comments, questions?
Yeah, I'll make one comment. I agree completely. We use re-entry devices for all kinds of CTOs, iliac CTOs, CTOs involving venous structures, very, very helpful and easier if you use it earlier, because it's you have more chance of getting the true lumen and not having to worry about dissection plans.
Yeah, I agree with Dr. Petrone as well as Dr. Miner. We use it very frequently for many reasons. First of all, you want to keep that skill set up so that you know really how to do it and how to use it. And so, you know, it decreases your time, because you're absolutely right. You see people that are just poking for hours because it becomes an ego thing. I'm like, pull that thing out and just do it and get it done. One of the things that was really interesting, I've never used an Outback or a Pioneer retrograde. Usually from a retrograde standpoint, if I'm going to use reentry device, it's going to be an interior, because you know, they have the 275 balloon, 375 balloons. It's a very low profile. Are there any limitations? Because it's a really great idea to do that. Any limitations from using the Outback device retrograde?
So yeah, very nice. Thank you for both your comments. And I think the limitation is the size. So essentially, both the Supera, the Outback, all these devices have a quite good profile. So personally, I don't see the need to put a sheath to go with these devices. So that the limitation of the size, as I also tried to stress during my presentation, is relative, because it's if you use a 6 French out diameter device, it's the same as a 4 French sheath. So no one is very worried about putting a 4 French sheath through a pedal access. So the same with an Outback, you know, or with a Supera. So I put Superas from all over the places, from the dorsalis pedis or from the anterior tibial artery proximally, and I think it's good. I never had a complication with bleeding, any significant bleeding. You know, I had one side dissection. I put a stent at the level of the proximal anterior tibial artery, and that's it. And also we were gonna very close to do the first in vivo study with a new re-entry device, which is gonna be electric guided. So essentially, with a wire from the, you know, of course, the other axis, it orientates without any kind of screening. So it goes extremely well. It will be a 4 French device, so it's going to be even smaller. And I mean, I've done already the first case in vivo, and I'm publishing it now. But we are starting now our trial with 15 cases, and I think this could be probably, I mean, not a game changer, but it could be something very nice. It's very handy, very low profile, and very good to be used, I think.
Wonderful, thank you.
Okay, this is great comments. Jan Skowronski. We will move to next presentation. Grzegorz, Dr. Grzegorz Stasiuk, you're on. Share your screen.
Hello, everybody. I'm Grzegorz Stasiuk. I'm from Przemyśl. Here's my presentation. I want to tell about new devices in femoropopliteal interventions. Every one of us knows that intervention in femoropopliteal segment of arteries are still a significant problem in our daily practice. We know that the natural properties of femoral and popliteal artery wall, the movement of this part of arteries, tendency to heavily calcified plaques, causes difficulties in crushing the lesions, angioplasty stenting, and finally a long-term patency. The first device I want to tell about is the TEN Pulsar 18 T3. Is indicated for use in patients with atherosclerotic disease. For superficial femoral, proximal popliteal, and infrapopliteal arteries, as well as for the treatment of insufficient PTA like residual stenosis and dissection. This is a thin strut stent with 3-axial shaft on a 4 French platform. The very important property of this stent is the thinner strands. The thinner struts causes lower chronic outward force, COF. It's important for outcomes. The lower COF results in lower risk of restenosis, reduces the visual injury, and reduces the inflammatory response. So allows a faster endothelialization and lowers the level of neo-intimal hyperplasia. There was a trial. The results of the trial was announced on September 2019. The trial BioFlex COF. It demonstrated that the implantation of stents with low chronic outward force was associated with less neo-intimal hyperplasia. resulting in less restenosis. This trial was initiated by an investigator. It's blinded prospective. The patient was divided in two randomized groups, and the de novo SFA lesions were treated with primary nitronal stenting, and something more. 83 patients with symptomatic peripheral artery disease were enrolled. The trial's primary endpoint is the amount of in-stent restenosis at 1 and 2 years, as assessed by contrast-enhanced CTA. The 1-year results showed significantly lower stenosis rate of low COF stents versus high COF. It's 27 versus 37%. Conclusions: this is the BioFlex COF trial is the first randomized controlled trial to assess COF. This is a real world, it's our daily practice. The 1-year follow-up is completed on July 2019, and total 2-year observation time is still in progress. Interim analysis show us significantly higher restenosis with higher COF stents. Something more properties of the stent. The stent has triaxial system, which is very useful, and the outer stabilizing shaft allows us to ensure accurate state deployment because it isolates the inner part of shaft from friction caused by introducer valve and from interaction interaction with the atherosclerotic plaques. So the procedure is really smooth and precise. Of course, very important feature is the lower profile. 45% smaller puncture area than 6 French is safer for patient and causes lower access site complication rates, involves shorter compression time, and no needs for closure device. Some technical specifications. The other device is carnelian support, is peripheral microcatheter support, which is useful. CTO crossing, guide wire support, and of course selective delivery of contrast media. A short diagram of how it works. And this is a portfolio of carnelian support microcatheters. One of them is 018 guide wire, is multi-purpose tool, and four of them use 014 guide wires. There are one multi-purpose tool, one for highly calcified lesion, one catheter for a very designed for very tortuous anatomies, is the thinnest in this family, in one for sheetless distal approach. Short diagram. And this carnelian support catheters are well visible in X-ray because of tungsten braided. And the thinnest has only 1.6 French diameter. That's really, really nice. And it allows us to cross much easier than with thicker devices. The multi-segment shaft design consists of few segments depending on the model, providing variable levels of support and flexibility along the shaft length. And some technical specifications and some examples of using these microcatheters. We can see the access from collateral, from anterior tibial artery to peroneal artery. The next one is crossing the highly calcified lesions in popliteal artery and distal from the femoropopliteal bypass. This is very nice. I like it very much. This is the example of crossing crossing through the transcollateral in the area of the foot. Another example, and also an example of crossing through collateral and recanalization of iliac arteries. Neptune partner vascular closing device is calcium alginate pad held over the access site. It shortens the compress time. It's very easy to use. We can remain it up to 24 hours after procedure. And at the end of presentation, I have one case, the patient admitted with symptoms of critical left lower limb ischemia with CTO in SFA, coronary disease, hypertension, COPD, anamnesis, patient on dual antiplatelet drug therapy. The patient, after a few intravascular interventions, technique was percutaneous antegrade left inguinal approach assisted with ultrasonography for French platform, crossing the lesion with a Stato XS20 guide wire, predilation with 3 mm balloon, and final PTA with stenting SFA PA with 5 mm balloon, and stenting with Pulsar 18 T3 5 mm diameter and 100 mm length stent. At the proximal part of SFA, we made a PTA with stent with Pulsar 18. Hemostasis closure device by Tony. That's the initial view. Predilation. Final.
This is Jan Grzegorz. We will need to be concluding. Show us the final angiogram. Looks like you're proceeding nicely
this
here.
is the final after PTA at lower and upper part. I decided to implant stent at the distal part of SFA and P1 and at the proximal part of superficial femoral artery. Thank you very much.
Thank you very much, Grzegorz. Are there any questions for Grzegorz from Przemyśl? Okay, guys, so I'm gonna I'm gonna skip my presentation, but I will just show you something for 1 minute. I will show a little trick, but if you have done more than 200 endovascular interventions, don't pay attention. It's only for younger operators, and it will allow you to cross a lot of stuff, a lot of SFAs that you previously haven't been able to cross. So I'm going to share screen. Okay. Are we good? Okay. So 1 second. Here we go. So this is a patient, I'm not kidding. This is my wife's boss's mother, who was 92 and demented and was scheduled for an amputation. So this is her initial angiogram. This is her angiogram 49 minutes later. And very simple trick to cross CTO of SFA. Essentially, and basically you always put a loop. So glide wire advantage, 035, Navicross from Terumo. You lock it together, you put a loop, and you put it as a loop, and you basically push it forward, and that will allow you to cross 80% of even long femoral popliteals, CTOs in an antegrade intraluminal fashion. We don't have time for more, so I would like to conclude the session. I would like to thank everyone for participation. Unless there are other questions regarding the session, I will go back to Warsaw. Thank you so much. Any questions, comments?
Can I just add one thing? I think there's a wire from Terumo, which is called, I don't know, we use it in Europe, maybe there's not in US, the semi-stiff Terumo, which has this kind of small knuckle tip on the top. So I think it's very useful, exactly because you said this trick, and this wire just does the trick. So if you have in your armamentarium, sometimes it's very useful, even for intraluminal recanalization of small vessels.
I haven't seen it. Write it to us on chat. Write it to everyone, the name of the wire. I haven't used it in the US. I don't know about my colleagues.
No.
Okay. All right. Thank you, guys. And back to Warsaw. Grzegorz and Jarek, thank you.